Welcome to the Radon Smart Review GU Cancer Series.
I am really excited for this one today
Yeah.
because, for decades, radiation oncologists and urologists basically looked patients right in the eye and told them their kidney cancer was totally radioresistant.
Right, like it was this impenetrable biological fortress.
Yeah, exactly. We treated it like radiation simply could not work, but, we were just completely wrong.
We were so wrong. And that is honestly the perfect place to start today's session, because the dogma of the radioresistant kidney tumor is officially dead.
Thank goodness.
Right. Today, we are focusing entirely on episode 25, which is renal cell carcinoma. Specifically, we're looking at RCC in the setting of oligometastatic disease, the ICI, that is, the immune checkpoint inhibitor era, and the, well, highly debated modern role of cytoreduction.
Yeah, and if you were walking into clinic tomorrow or, sitting for your oral boards in a few months, you absolutely have to understand that metastatic RCC management has undergone a total revolution.
A complete 180.
Totally. We are looking at a collision of three major practice paradigm shifts, and they are all happening at the exact same time.
Yeah, so the first shift is exactly what you just mentioned, right? The death of that radioresistant dogma. Because when we used conventional radiation, meaning, standard daily fractions of 1.8 or 2 gray, the tumors practically laughed at us.
They really did. The tumor cells just had these incredibly robust, sublethal DNA repair mechanisms, so they'd heal overnight.
Exactly. But the modern use of ablative SBRT, stereotactic body radiation therapy, it completely changed the physics and the biology of how we treat this disease. We are not just causing standard double-strand DNA breaks anymore.
Right. We are physically obliterating the tumor microvasculature. We are triggering endothelial cell apoptosis via the ceramide pathway.
Oh, the ceramide pathway, right.
Yeah, and that only happens when we use high-dose perfraction SBRT. The second massive shift, though, that sits entirely in the surgical realm.
The cytoreductive nephrectomy.
Exactly. Historically, that was an automatic knee-jerk reflex. If a patient presented with a primary kidney mass and, say, metastases in the lungs or the bones, the urologist took the kidney out immediately, period.
No questions asked.
Right. But now that procedure has been severely downgraded. It's no longer a reflex at all. It is a highly selective, risk-adapted tool, and we only use it for specific patients at very specific times.
And the third shift is really the engine driving the other two. It's the systemic therapy revolution.
Oh, absolutely.
Because the rise of immune checkpoint inhibitor combinations, the ICI drugs, as the absolute backbone of first-line metastatic therapy, it altered everything. These modern systemic therapies are so incredibly effective at shrinking tumors and extending life that they essentially dictate how and when we sequence our local therapies.
Yeah, like radiation and surgery.
Yeah.
But before we get too deep into the data, we really need to issue a massive warning for anyone studying for the boards right now.
Yes, please.
Do not fall into the trap of treating metastatic RCC, like oligometastatic prostate cancer or, oligometastatic breast cancer.
Right. The biology is completely different.
Totally different. In RCC, rigid risk stratification is uniquely vital. You cannot overgeneralize here. You have to know precisely when the systemic backbone comes first, when surgery is actually appropriate, and exactly where SBRT adds value.
Right, mechanical or sequencing value without overselling its biological effects. So I think the cleanest way to map out this really complex algorithm is to anchor our whole discussion to a realistic clinical case.
I love that. Let's do it.
Okay, so we're seeing a 62-year-old man in consultation today. He is otherwise completely healthy, works full-time, very active. He has an ECOG performance status of 0.
Okay, perfect.
And ECOG, of course, being the Eastern Cooperative Oncology Group scale, so 0 means he is fully active, totally asymptomatic.
Got it. So what brings him in?
Well, he initially goes to his primary care physician complaining of this nagging, persistent lower back pain. It just hasn't responded to physical therapy or, over-the-counter pain medications.
Okay, so a vague mechanical symptom.
Exactly. And that prompts his doctor to order some cross-sectional imaging. They get a CT, a computed tomography scan of his abdomen and pelvis. And the imaging incidentally reviews the source of the entire problem.
Let me guess. A huge kidney mass.
Nailed it. A large 8-centimeter enhancing mass in the left kidney. But crucially, when we look at the venous anatomy on that CT scan, there is no IVC thrombus.
Oh, that's a huge detail.
Yeah, the inferior vena cava is completely clear. There is no adjacent organ invasion, so it hasn't invaded the bowel or the psoas muscle, and his contralateral right kidney looks perfectly normal.
Right, and just to emphasize for the listeners, a
Hmm.
clear IVC is a very important surgical detail because if you have tumor thrombus extending into the renal vein and up into the inferior vena cava, that drastically changes the surgical morbidity.
Oh, absolutely. The immediate risk of tumor embolization during surgery goes way up.
Exactly. But in this case, the local anatomy is relatively clean, despite the primary mass being 8 centimeters. So we then proceed with the mandatory staging workup, right?
Right.
We get a CT of the chest, and unfortunately, that reveals 2 peripheral lung nodules. One is sitting in the right lower lobe, and the other is in the left upper lobe.
And the imaging also catches the source of his chief complaint, right? Down in his lumbar spine, there is a single lytic lesion in the L3 vertebral body.
Okay, L3.
Yeah. But importantly, the CT and the subsequent MRI, the magnetic resonance imaging of his spine, show that there is no epidural extension. The tumor is completely confined to the bone of the vertebral body. It's not compressing the middle sac or the spinal cord at all.
That is definitely good news. And I assume we also obtain a baseline MRI of the brain.
We do, and it is completely negative for intracranial metastases.
Awesome. Let's pause on the staging workup for just a second here,
Yeah.
because you cannot talk confidently about local therapy in metastatic RCC without confirming a complete staging checklist.
It's mandatory.
Right. You absolutely need contrast-enhanced cross-sectional imaging of the chest, the abdomen, and the pelvis. You definitely need a baseline brain MRI.
Yeah, especially when you're considering major systemic therapy or obviously if the patient has any neurologic symptoms.
Exactly. And you need symptom-guided imaging, which in this case was that dedicated spine MRI to evaluate his back pain.
Right. And you also definitively need tissue confirmation. You can't just guess. So a biopsy of the primary left renal mass is performed, and the pathology report confirms clear cell renal cell carcinoma.
The classic.
Yeah, clear cell is the most common histology. And it's driven heavily by alterations in the VHL, the von Hippel-Lindau tumor suppressor gene pathway.
Right, which leads to the overproduction of VEGF.
Exactly, VEGF and profound tumor angiogenesis, which is why these tumors are so incredibly hypervascular and they enhance so vividly on CT scans.
Yeah, they light right up. We also run his baseline laboratory workup. Let's see, his hemoglobin is completely normal. His corrected serum calcium is normal. Absolute neutrophil count is normal. Platelet count is normal. And as we already established, his performance status is excellent.
He looks great on paper. But here is the single most critical detail of this entire case. It is the detail that will literally make or break your treatment algorithm.
The timeline.
Yes, the timeline. The time from his initial diagnosis today to the planned start of his first-line systemic therapy is less than 1 year.
And that is the absolute pivot point because, his blood work is completely pristine and he looks fantastic walking into the exam room. So the natural psychological instinct for a clinician is to reflexively label him as having favorable risk disease.
Right. You just want to say, oh, he's fine. He's favorable.
Exactly. But you have to fight that instinct because he is presenting with de novo metastatic disease, meaning his metastases are present right now. At the time of his initial diagnosis, the time from diagnosis to needing systemic therapy is obviously under 1 year.
Right.
And that single temporal fact automatically assigns him one risk factor.
And one risk factor means this patient has strictly intermediate risk disease. That distinction completely alters the frame of the consultation. If we just assume he's favorable risk, we go down a very specific historically surgical pathway.
Which would be totally wrong for him.
Totally wrong.
Yeah.
Because he has intermediate risk, our entire approach to his massive kidney tumor, his spine metastasis, and his systemic therapy has to completely change.
And that clinical categorization brings us directly to the IMDC risk framework, right? Which stands for the International Metastatic RCC Database Consortium.
It's a mouthful, but it's essential.
Yeah, you simply cannot make a modern treatment decision without calculating this score. It is the absolute foundation of metastatic kidney cancer management.
There are 6 specific factors in the IMDC criteria. They consist of 5 laboratory and clinical parameters plus the performance status. To help secure this for the boards, we usually rely on a short mnemonic.
Oh, I love mnemonics. What is it?
Think of the phrase, time to catch high platelets and neutrophils.
Time to catch high platelets and neutrophils.
Yeah.
Okay, let's break that down logically. So the word time stands for the time from initial diagnosis to the initiation of systemic therapy being less than 1 year.
Exactly. And the word to is simply a grammatical connector, so we ignore that. The word catch represents calcium, specifically a high corrected serum calcium level.
The mechanism behind that high calcium is actually really fascinating. It is usually a paraneoplastic syndrome, right, where the RCC secretes a parathyroid hormone-related protein.
PTHRP, yeah.
Right, and that just pulls calcium right out of the bones and into the blood. Okay, then we move to the word high in our mnemonic.
This is actually a deliberate trick to remind you of hemoglobin, but specifically it's a low hemoglobin level, meaning anemia.
Right, hemoglobin is the only laboratory value in this list that drops, while all the others elevate.
Exactly. And the anemia is often an anemia of chronic disease, or it's driven by the massive systemic inflammatory burden of the cancer itself.
Makes sense. Moving on, the word platelets stands for a high platelet count, or thrombocytosis. And neutrophil stands for a high absolute neutrophil count.
Right, and both of those are driven by tumor-mediated cytokine release.
Particularly interleukin-6.
Well, yeah, IL-6 just ramps up the bone marrow. So, reviewing the 5 factors from the mnemonic: time to systemic therapy under 1 year, high calcium, low hemoglobin, high platelets, high neutrophils.
And the sixth and final factor, which kind of sits outside the mnemonic but is tied to the patient's physical state, is a Karnofsky performance status of less than 80%.
Right, and once you tally up those 6 factors, the scoring framework is incredibly rigid. If a patient has 0 factors, they are classified as favorable risk. If they have 1 or 2 factors, they are intermediate risk.
And if they have 3 to 6 factors, they are poor risk.
We really must emphasize why this framework is so critical. It entirely dictates your frontline systemic treatment options, and it heavily influences how you counsel the patient regarding surgery.
Yeah, if you miscalculate the IMDC risk group during a case presentation, your subsequent treatment plan will immediately sound outdated and, frankly, clinically dangerous.
Highly dangerous. So, applying this to our 62-year-old case anchor, his Karnofsky performance status is 100, so he gets 0 points there. His calcium, hemoglobin, platelets, and neutrophils are all perfectly within normal limits.
0 points there, too.
Right. However, because he has de novo metastatic disease, the time from his diagnosis to systemic therapy is under 1 year. That gives him exactly 1 factor.
And 1 factor drops him firmly and undeniably into the intermediate risk category. So now that we have accurately staged him and rigidly defined his risk group as intermediate risk clear cell RCC, we have to build his systemic therapy backbone.
Which brings us back to the third paradigm shift we introduced at the very beginning of the discussion. In the modern era, the frontline systemic therapy backbone for an intermediate risk patient is an IO-based combination.
An immune checkpoint inhibitor regimen.
Exactly. And let's talk about what we are not doing, right? The old standard was to start almost everyone on a single-agent TKI, a tyrosine kinase inhibitor like sunitinib or pazopanib.
Yeah, the old VEGF targeting approach.
Right, to starve the tumor of its blood supply. But for this patient's presentation today, that single-agent TKI approach is completely obsolete. You must banish the concept of monotherapy TKI from your treatment algorithms for intermediate risk disease.
Banish it entirely. Instead, we are looking at powerful combinations. The major practical IO combination regimens you really need to be familiar with are combinations of an immunotherapy drug with a targeted drug or dual immunotherapy.
Right, so examples would include pembrolizumab plus axitinib or lanretinib plus pembrolizumab, or nivolumab plus cabozantinib. Those are the IO plus TKI combinations.
And then you have the dual IO combination, which is nivolumab plus ipilimumab. Nivolumab is a PD-1 inhibitor blocking the programmed death receptor on T cells to prevent tumor cells from, turning the immune system off.
And ipilimumab is a CTLA-4 inhibitor.
Exactly, which acts earlier in the immune cycle. It essentially takes the brakes off T cell activation right there in the lymph nodes.
So the logical board-style way to frame systemic selection is that IO plus DKI combinations are widely accepted frontline options across all IMDC risk groups: favorable, intermediate, and poor.
Yeah, they work across the board.
However, The dual IO combination of nivolumab plus ipilimumab is heavily established and specifically utilized in intermediate risk and poor risk disease.
And that's really based on the Checkmate 214 trial data, right? Which showed a massive overall survival benefit compared to sunitinib.
Oh, massive. And just a brief pathology pearl to keep in your back pocket here. If the biopsy had demonstrated sarcomatoid features, which our patient does not have, he has pure clear cell.
Right, pure clear cell.
But if sarcomatoid dedifferentiation is present on pathology, those tumors are notoriously aggressive, but they are highly responsive to immune-based therapy. So dual IO becomes incredibly attractive in that specific scenario.
That's a great pearl. But the goal here is not to play medical oncologist and memorize every single hazard ratio of every phase 3 trial. The critical action item is to confidently state that for this intermediate risk patient, a modern IO-based combination is the mandatory systemic backbone.
And you do not reach for an outdated single-agent TKI.
Period.
Period. So now that we have established the systemic foundation, we run headfirst into the most heavily debated surgical question in modern genitourinary oncology.
Cytoreductive nephrectomy.
Yes. What do we actually do with this massive 8-centimeter left kidney primary tumor?
Well, historically, the decision tree was practically non-existent. The patient had a kidney mass and distant metastases, so you called your urology colleagues, and they literally excised the kidney immediately prior to initiating any systemic therapy.
Right. The biological theory was that the primary tumor was this, like mothership acting as an immunosuppressive sink, constantly shedding tumor cells and cytokines.
Yeah, they believed that removing it would inherently improve overall survival, or at least allow the older systemic therapies, like interferon or interleukin-2, to function more effectively.
But that reflex dogma has been totally dismantled, and understanding exactly why it changed is vital for the boards. The shift was driven primarily by 2 landmark trials, Carmina and Certime.
We really need to dissect what these trials actually proved, because they are frequently misquoted or just oversimplified in tumor board discussions. Let's dissect Carmina first.
Okay, Carmina.
The Carmina trial enrolled patients with metastatic clear cell RCC who were slated to receive systemic therapy. They randomized these patients into 2 arms. The first arm received the historical standard of care, an immediate upfront cytoreductive nephrectomy followed by the TKI sunitinib.
And the second arm.
The second arm skipped the surgery entirely and just received sunitinib alone.
And the results sent absolute shockwaves through the urologic community. The trial demonstrated that upfront surgery followed by sunitinib was not superior to systemic therapy alone.
Not at all.
In fact, the sunitinib alone arm was proven to be non-inferior for overall survival. Many patients in the surgery arm progressed so rapidly after their nephrectomy that they never even recovered in time to receive their systemic therapy.
Yeah, that was the real tragedy of the upfront surgery approach. So the practical clinical takeaway from Carmina is highly nuanced. The lesson is not that cytoreductive nephrectomy is a useless, dead procedure.
Right. We still do it sometimes.
Exactly. The true lesson is that immediate, upfront cytoreductive nephrectomy should no longer be an automatic reflex in intermediate or poor-risk patients who clearly require immediate systemic control.
Because the systemic disease is what kills the patient, not the primary tumor. So delaying systemic therapy for a major abdominal surgery is just biologically backward.
Biologically backward, well said. And then we look at the Certime trial, which added this brilliant conceptual layer to the whole problem. Certime was designed to evaluate sequencing.
So it wasn't just surgery versus no surgery.
Right. It randomized patients to either immediate cytoreductive nephrectomy followed by sunitinib versus starting with sunitinib first and then performing a delayed, deferred cytoreductive nephrectomy only in the subset of patients whose disease responded well to the systemic drug.
And while Certime suffered from poor accrual and was ultimately underpowered, meaning, you really should not oversell it as definitive, statistically unassailable proof on the boards.
True, you have to be careful with underpowered trials.
Right. But the biological logic it supported is deeply embedded in modern practice. It established the strategy of using systemic therapy as a test of time.
The test of time. I use that phrase in clinic all the time. You initiate the systemic therapy first, and you use the patient's physiological and radiographic response to that treatment as a dynamic selection tool.
Exactly. It allows you to identify the patients who actually have favorable biology. Because if a patient starts an IO combination and their disease completely explodes 3 months later with new liver and bone metastases rapidly appearing on the interval CT scan,
taking out their kidney up front would have been a catastrophic error. You would have subjected them to massive surgical morbidity, a really prolonged recovery, and potentially delayed the exact systemic drugs they desperately needed.
All while their systemic disease raged totally out of control.
So what is the precise modern teaching consensus you must articulate when evaluating a case like this? It should sound exactly like this. We do not perform a routine, immediate cytoreductive nephrectomy in intermediate risk or poor risk patients who require systemic therapy.
Period.
Period. Instead, we initiate the systemic backbone first. Then, and only then, we discuss the potential for a deferred nephrectomy later on, provided the patient demonstrates a meaningful clinical response to the drugs, remains medically fit for a major operation, and their disease biology proves itself to be indolent over time.
Which naturally raises the question, are there any scenarios left where immediate upfront nephrectomy remains the correct choice today?
Oh, definitely. Yes, there are, but they are highly selective.
Right. If you evaluate a favorable risk patient with pristine performance status, perfectly normal labs, and perhaps one tiny, completely asymptomatic lung nodule that does not mandate immediate systemic therapy, upfront surgery is completely reasonable.
Yeah, that makes sense. Another valid scenario is a true, highly limited oligometastatic presentation, where you have high confidence that you can completely and definitively eradicate all visible disease using local modalities.
Like taking out the primary kidney tumor surgically and simultaneously using SBRT to ablate a single solitary bone metastasis.
Exactly. And keeping the patient completely off systemic therapy in the process.
But those highly selected favorable risk scenarios are vastly different from our 62-year-old case anchor today.
Vastly different.
Our patient is definitively intermediate risk. He has multiple sites of systemic disease, including the lung nodules and a very painful symptomatic bone metastasis. The biological clock is ticking, and he requires systemic therapy now.
No. We must agree, and a modern urologist would agree, that we absolutely do not send this man straight to the operating room for a nephrectomy.
So the plan is clear. We start him on an IO-based systemic therapy combination. We hold the cytoreductive nephrectomy option in our back pocket. We will reevaluate his imaging in a few months.
And if he has a phenomenal systemic response, and the primary tumor is the only site of residual active disease, then we can revisit the deferred surgical option.
Right. So we have solidified the staging, the IMDC risk group, the systemic therapy plan, and the surgical strategy. But because we just proved surgery isn't his immediate answer, we are left with a massive 8-centimeter primary tumor and a highly painful bone metastasis.
Right. How do we control those locally if the surgeon won't touch them yet?
That is exactly where the modern application of radiation oncology steps in. We really need to completely demystify the use of SBRT in the RCC space.
To do that, we have to formally kill the radioresistant myth we touched on earlier. You will inevitably hear older practitioners or, even colleagues in other specialties claim that radiating kidney cancer is just a waste of time.
I still hear it sometimes.
It's crazy. But the precise, scientifically accurate way to counter this is to explain that renal cell carcinoma responds poorly to conventional standard fractionation.
Right. When we deliver standard definitive or palliative radiation, say 30 gray in 10 fractions or 2 grays per day for several weeks, we are relying on the generation of reactive oxygen species to cause DNA double-strand breaks.
And RCC cells are incredibly adept at repairing this specific type of sublethal radiation damage before the next daily fraction is even delivered.
They essentially heal themselves overnight.
Yeah, but when we transition to SBRT, delivering massive high-dose per fraction radiation, such as 24 gray in a single fraction or 27 to 30 gray in 3 fractions, we completely overwhelm and shatter those cellular repair mechanisms.
The linear quadratic model of radiation biology literally begins to break down at these extreme doses. We stop relying solely on DNA damage and begin triggering entirely different biological pathways.
Exactly, like we mentioned, the extreme dose per fraction causes catastrophic damage to the endothelial cells lining the tumor's blood vessels. This triggers massive endothelial apoptosis via the ceramide signaling pathway.
And then the blood supply to the tumor just collapses.
It completely collapses, leading to secondary ischemic necrosis of the entire tumor bed. Because of this dual mechanism, DNA damage plus vascular collapse, SBRT achieves phenomenally high rates of local control in RCC, often exceeding 90%.
90%? That's incredible for a disease they used to call a biological fortress.
Right. So having established the biological efficacy of SBRT, we have to define exactly when and why we deploy it clinically. They're two completely distinct SBRT paradigms in the metastatic setting.
And you must keep them strictly separated in your mental framework because the ultimate goals of care are entirely different. The first scenario is the systemic therapy naive oligometastatic state.
Okay, now,
This describes a patient who has a very limited metastatic burden, perhaps one or two small lesions, and who has not yet initiated any systemic medical therapy. The primary overriding clinical goal of using metastasis-directed SBRT in this scenario is to delay the initiation of systemic therapy.
right, systemic therapy deferral. We now have robust prospective phase 2 data supporting this exact approach. By using SBRT to locally ablate the few visible spots of disease, we can safely buy the patient a significant treatment-free interval.
Sometimes we can defer systemic therapy for years.
Years. And this spares the patient the intense financial toxicity of these modern drugs, the daily chronic fatigue and diarrhea associated with TKIs, and the potentially permanent life-altering immune-related adverse events associated with IO combinations.
Like pneumonitis or colitis or adrenal insufficiency. Buying a patient 2 years off therapy is a massive quality of life victory.
Oh, huge victory. Now, the second scenario is entirely different. This is the concept of oligoprogression. In this situation, the patient is already actively receiving a systemic therapy regimen.
So let's imagine our 62-year-old patient starts his pembrolizumab plus axitinib. He stays on it for 18 months. His primary kidney mass shrinks, his lung nodules disappear, his disease is profoundly well controlled.
But suddenly, on a routine surveillance CT scan, one single spot, perhaps a new adrenal gland metastasis, figures out a biological escape pathway and begins to grow aggressively.
That is the definition of oligoprogression. And the traditional historical approach in medical oncology would be to declare that the entire systemic therapy regimen has failed.
Right, they would stop the pembrolizumab and axitinib entirely and switch the patient to a second-line, potentially far more toxic systemic therapy.
But SBRT fundamentally changes that entire algorithm. The goal of SBRT in oligoprogression is what we colloquially call weeding the garden.
Weeding the garden.
Yeah, RCC is notoriously heterogeneous. That growing adrenal mass likely represents a single subclone of tumor cells that has developed resistance to the immune therapy.
So instead of throwing away a drug that is still successfully suppressing microscopic disease everywhere else in the body, we use focused high-dose radiation to physically ablate that one single rogue progressing lesion.
And by mechanically weeding that one bad spot, we can keep the patient on their current well-tolerated systemic drug for much longer. We are artificially extending the clinical lifespan and the ongoing benefit of that systemic therapy.
Exactly. So to summarize the exact terminology you should utilize. For upfront oligometastatic disease, you are aiming for a systemic therapy deferral in highly selected patients. For oligoprogression, you are aiming for the extension of benefit from an ongoing systemic therapy backbone.
Perfect. Which brings us to the biggest, most dangerous SBRT trap you will face on your oral boards.
So this is a big one.
An examiner will present a case and then purposefully push you. They will ask, "Doctor, are you recommending SBRT to that lung nodule because you are attempting to trigger an abscopal effect and create immune synergy with the pembrolizumab?"
And you must shut that premise down firmly, respectfully, but instantly.
Instantly. It is true that there is an enormous amount of fascinating preclinical and biological interest in combining high-dose radiation with immune checkpoint inhibitors.
Yeah, the theory is that radiation acts as an in situ vaccine, shattering the tumor cells, releasing a flood of neoantigens, and priming dendritic cells to activate T cells against systemic microscopic disease.
The abscopal effect.
Right. But clinically, in the real-world management of RCC, the cleanest, most defensible, and evidence-based reason to use SBRT is strictly for local tumor control, durable symptom relief, and treatment sequencing. You use it to solve a mechanical problem or to weed the garden.
Right. Do not oversell an unproven magical survival synergy on your oral boards. While trials are ongoing, it is not scientifically accurate to claim that SBRT plus ICI has definitively proven a massive survival advantage based purely on a systemic abscopal immune mechanism in RCC.
You radiate the lesion because you want that specific lesion dead, period.
Period. Let's transition this theoretical logic into site-specific local therapy and definitively resolve the management for our 62-year-old case anchor.
So the most pressing immediate local issue he faces is that single lytic lesion in his L3 vertebral body. It is the source of his chief complaint, that nagging, debilitating lower back pain.
And treating a lytic bone metastasis with radiation requires a deeply mechanical way of thinking. A lytic lesion means the RCC tumor cells have literally eaten away the trabecular calcium and the internal structural integrity of the
It
bone.
is completely hollowed out.
Exactly. I rely heavily on an analogy when explaining the specific pathophysiology to patients in the clinic, and it perfectly illustrates the concept. Compare treating a lytic bone metastasis with radiation to hiring an exterminator to eradicate termites from a critical wooden support beam in the basement of your house.
That is an exceptional visualization. Because when we deliver the high-dose SBRT to the L3 vertebral body, the radiation acts exactly like the exterminator's chemical poison. It annihilates the tumor cells with extreme prejudice.
That achieves your biological control. The termites are dead.
But here is the critical flaw in the patient's intuition. Even though the termites are dead, the structural integrity of that wooden support beam is still completely compromised. It's
Yeah.
still a hollow shell.
Right. The SBRT achieves biological tumor control, but it does absolutely nothing to immediately restore the mechanical stability of the bone. In fact, due to the intense inflammatory response and localized edema caused by the radiation, it might transiently weaken the bone even further in the acute setting.
And because of that undeniable mechanical reality, your very first action when evaluating a patient with a spinal metastasis is never to open your treatment planning software and start drawing target volumes.
No.
Your first mandatory action is to formally assess spinal stability. You must calculate the SINS criteria, the Spinal Instability Neoplastic Score.
The SINS criteria is an absolutely vital tool. It evaluates 6 distinct parameters. First, location. Is the tumor in a highly mobile junctional spine region like the cervicothoracic or thoracolumbar junction, which carries way more mechanical stress?
Second, the nature of the pain. Is it mechanical pain that worsens with movement and weight bearing, which strongly implies instability?
Third, the nature of the bone lesion. Is it lytic, which is inherently weaker, or blastic?
Fourth, radiographic alignment. Is there already subluxation or deformity?
Fifth, the degree of vertebral body collapse. Is there greater than 50% height loss?
And finally, the sixth factor involved the posterior elements.
Uh,
Is there bilateral involvement of the pedicles or facets, which heavily compromises the posterior weight-bearing column?
You tally those points, and if the SIS score indicates clinical instability or impending instability, you must immediately coordinate with your orthopedic oncology or neurosurgical spine colleagues before you even consider delivering ablative radiation.
Yeah, they may need to perform an upfront stabilization procedure, such as a cement kyphoplasty or open hardware fixation, to actually secure the beam before you poison the termites.
And this profound focus on mechanical stability leads directly into a massive toxicity counseling pearl that you really must master. When you are sitting in the consultation room going through the informed consent process for spine SBRT, you do not tell the patient that the radiation will immediately reduce their risk of a bone fracture.
Right, that is completely backward logic.
Yeah.
Spine SBRT is phenomenally effective for durable local tumor control, and it is excellent for providing long-term pain relief. However, vertebral compression fracture of VCF is a major, highly documented, and heavily tested late toxicity of spine SBRT.
Because the intense radiation dose causes localized vascular necrosis of the remaining bony trabeculae?
Exactly. You have to explicitly and clearly counsel the patient that the irradiated vertebral body may ultimately collapse months or even years down the road as a direct consequence of the successful treatment.
You must be especially vigilant regarding this risk when treating purely a lytic disease, if there is already a pre-existing mild fracture or deformity, or when you are utilizing extreme high-dose per fraction regimens, such as 24 Gray in a single fraction.
Absolutely. So moving past the spine, let's briefly address his other sites of metastatic disease. He has those 2 peripheral lung nodules. From a purely technical standpoint, using SBRT for lung lesions is incredibly attractive.
Very. We can deliver highly conformal dose distributions, and it is highly effective at achieving local control. But the key question in a multidisciplinary tumor board is never simply, can we technically hit them? We can easily hit them.
The strategic question is, does hitting them right now actively advance the patient's overall treatment strategy?
Right. If the multidisciplinary team collectively decides to pursue a comprehensive upfront oligometastatic eradication strategy, simultaneously treating the lung nodules makes clinical sense.
And when we do treat the lung with SBRT, the standard toxicities we counsel on remain radiation pneumonitis, localized chest wall pain, and rarely a late rib fracture depending on exactly how close the peripheral tumor sits against the chest wall.
We should also briefly note that his baseline brain MRI was negative, But just for completeness regarding how we manage RCC brain metastases,
Hmm.
you must avoid relying on old blanket rules.
Yeah, modern intracranial management is entirely individualized. We predominantly utilize SRS, stereotactic radiosurgery, or fractionated SRS for a limited burden of brain metastasis.
We aggressively reserve whole brain radiation therapy, whether that is hippocampal avoidance, WBRT, or standard WBRT, as a highly selective tool. It's dependent entirely on the total volume of disease, the patient's overall systemic prognosis, and the severity of their neurologic symptoms.
So let's synthesize all of these complex moving parts and finalize a comprehensive evidence-based management plan for our 62-year-old patient.
Step one is defining the systemic foundation. Because he has de novo metastatic clear cell RCC with a time to systemic therapy of under 1 year, he is strictly intermediate risk. Therefore, we immediately start him on a frontline IO combination systemic therapy backbone.
That is the engine that will drive his overall survival. Step 2 addresses his symptomatic local disease. We will perform SBRT to that lytic L3 vertebral lesion.
Right, the goal here is achieving durable pain relief and definitive local control of the bone metastasis. However, we will only proceed with radiation after performing a rigorous mechanical clearance using the SINS criteria and consulting with spine surgery if necessary to ensure the L3 vertebra is mechanically stable enough to irradiate safely.
Step 3 addresses the primary tumor. We firmly hold off on the cytoreductive nephrectomy. We do not perform reflex surgery in this intermediate risk setting. We will observe his physiological and radiographic response to the systemic IO combination over several months, and we will reassess the potential utility of deferred surgery later, relying on the test of time.
And step 4 addresses the minimal volume lung disease. For the 2 peripheral lung nodules, we can safely observe them initially as he begins his systemic therapy, relying on the immune checkpoint inhibitors to shrink them.
Or, alternatively, we can treat them with SBRT based on a multidisciplinary consensus if the specific goal is comprehensive upfront metastatic eradication. Usually, seeing how they respond to the systemic therapy first is a highly reasonable and cautious path.
So if you had to summarize this massive, complex, multidisciplinary plan into a strong, simple, and compassionate counseling line for the patient sitting across from you in clinic, it would sound something like this.
Okay, let's hear it.
We are treating this as a systemic disease, so the intravenous medication we start is the foundation of everything we do to extend your life. Radiation still plays a crucial targeted role. For your spine, our goal is to permanently control that tumor and relieve your back pain, but we will constantly monitor the structural stability of the bone because the intense radiation can sometimes cause the bone to slowly collapse later on. For the small spots in your lung, focused radiation might be useful if it fits into our overall strategy to keep the total volume of your disease as low as possible. As for major surgery to remove your kidney, that is simply not an automatic first step anymore. We will start with the systemic medication, monitor your scans very closely, and we will decide together down the road whether removing the kidney will actually add meaningful value to your life.
Wow. That is an exceptionally balanced, honest, and modern way to counsel a patient. It respects the underlying biology of the disease, it sets clear mechanical expectations, and it aligns perfectly with the realities of the modern clinical data.
We have covered an immense amount of ground today. To make sure these concepts are truly locked in, we are going to transition into the board blitz.
My favorite part.
We are going to rapid-fire 3 high-yield clinical scenarios that test the exact boundaries of what we just discussed. These are the specific nuances where residents routinely stumble.
Let's run through them. Scenario 1. You are evaluating a newly diagnosed metastatic clear cell RCC patient in consultation. The primary kidney tumor is still in place. They have multiple visceral metastases in the liver and the lungs.
Okay.
When you calculate their IMDC score, they have poor risk features, and they clearly require immediate systemic therapy to control their rapidly progressing disease. However, from a purely cardiopulmonary standpoint, they are completely medically fit for surgery.
Yeah.
Do you send them straight to urology for an upfront cytoreductive nephrectomy?
No, absolutely not. The fact that they are physically fit enough to survive the anesthesia does not mean the surgery is biologically correct. In a patient who requires immediate systemic treatment, upfront cytoreductive nephrectomy is no longer routine. It is especially inappropriate and potentially harmful in a patient with poor risk disease features. They need their systemic therapy initiated immediately without the multi-week delay required to recover from a major abdominal operation.
Precisely. You do not operate just because you can.
No.
Scenario 2. A patient has been on the systemic combination of nivolumab plus cabozantinib for over a year. Clinically, they're doing fantastic, but on their latest quarterly restaging CT scan, one single adrenal metastasis begins to enlarge significantly, while the primary tumor and every other site of metastatic disease remains perfectly stable or radiographically undetectable.
Ah, okay.
What is this specific clinical state called, and how do we manage it?
That is the textbook definition of oligoprogression. We absolutely do not abandon the nivolumab plus cabozantinib regimen because it is still clearly working for 99% of the disease burden in the patient's body.
Right, keep the drug going.
Instead, we utilize SBRT to locally ablate that single rogue growing adrenal lesion. By weeding the garden, we prolong the clinical usefulness and the overall lifespan of the current systemic drug combination.
Exactly. You keep them on the drug that is working for the rest of their body.
Yeah.
Final scenario, question 3. A patient is receiving extreme high-dose SBRT for a painful, purely accelerative spine metastasis originating from their RCC. Beyond the standard acute toxicities like fatigue or transient pain flares, what specific, major late mechanical effect must you explicitly counsel them on during the consent process?
You must heavily counsel them on the late risk of a vertebral compression fracture. The intense ablative radiation provides excellent biological control of the tumor cells, but the mechanical integrity of that hollowed-out oolitic bone remains compromised.
Right.
The localized vascular necrosis caused by the radiation means the bone cannot remodel properly, and the vertebral body can ultimately collapse under normal physiological load over time.
That is spot on. If you can smoothly navigate those 3 complex scenarios and articulate the reasoning behind them, you are in phenomenal shape for clinical practice and the boards. Let's do a quick collaborative summary of the golden rules we established today to tie it all together.
Rule number 1. Always calculate the exact IMDC risk group before making a single treatment recommendation. Rely on the mnemonic time to catch high platelets and neutrophils.
And permanently remember that presenting with de novo metastatic disease means the time to systemic therapy is under 1 year. That automatically pushes a perfectly healthy-looking patient out of the favorable risk category and squarely into intermediate risk.
Rule number 2. The modern frontline systemic backbone for intermediate and poor-risk patients is essentially always an IO-based combination. Whether that is dual immunotherapy or an IO plus TKI combination, we have completely moved past the historical era of single-agent TKI monotherapy as the default answer.
Rule number 3. Cytoreductive nephrectomy is now a highly selective and frequently deferred procedure, not an automatic reflex. For intermediate and poor-risk patients who mandate systemic therapy, you initiate the systemic therapy first, you let the biology reveal itself, and you consider surgery only as a deferred option in excellent responders.
Rule number 4. SBRT is highly effective for overcoming RCC's traditional resistance to standard fractionation. Use it deliberately for systemic therapy deferral in truly upfront oligometastatic cases or for weeding the garden in the setting of oligoprogression.
But firmly justify your SBRT with proven local control and treatment sequencing logic, rather than chasing a magical, unproven immune abscopal synergy.
And finally, always respect the underlying mechanical stability of the bone when treating oolitic spine metastases. The biological termites may be eradicated, but the structural damage to the wooden beam remains a permanent mechanical risk.
That comprehensively covers the core of modern metastatic RCC management, but it leaves you with a truly fascinating clinical thought to ponder as you walk away from this session today.
What's that?
Well, we have talked extensively about utilizing SBRT to ablate visible macroscopic oligoprogressive spots on a CT scan to keep a systemic drug working. But what happens to our paradigm when liquid biopsies and circulating tumor DNA assays become sensitive enough to detect oligoprogression on a purely molecular level?
Oh, like perhaps 6 months before we can even see that adrenal mass growing on a scan.
Exactly. How will we aim our radiation to weed the garden when we know the disease is progressing, but the target is entirely invisible to our imaging?
That is an amazing question to end on. Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.